Greetings. Welcome to Mental Health and Faith-Based Communities, a special presentation by the Community Operations Department at Cardinal Innovations Healthcare. My name is Monae Davis. I am a Member Engagement Specialist.
And my name is Terrell, Alston. I'm a Regional Affairs Manager with Cardinal Innovations Healthcare. Cardinal Innovations is a specialized behavioral health plan that assists North Carolina residents that receive Medicaid in support for their behavioral health and wellness needs. The mission of Cardinal Innovations is to improve the health and wellness of our members and families.
So for today's presentation, some objectives are to define mental illness and spirituality, review common mental health illnesses and cultural impacts, review the state of crisis and trauma, have a discussion around stigma of mental health in relation to spirituality, and identify ways the faith-based communities can support. And then we'll also go through some additional resources. Mental health and faith-based communities. Faith communities may be the first place to which many turn for support. Faith communities are numerous and evenly distributed geographically. Faith groups already provide an educational setting, and faith groups are already committed to caring and advocating for a better world. People with mental health, MH, or intellectual or developmental disabilities, also known as IDD, or substance use disorders, SUD challenges, they still want to be connected to their faith communities. So it's important that people without these challenges, or just like people without these challenges, people with mental health, IDD, or SUD conditions have unique strengths and gifts that they bring to the faith community. People with these different challenges in their families may also desire support of their faith communities, but many faith communities may not be sure how to best support this specific population. And so, again, that's pretty much why we want to have this dialogue or this presentation about ways that individuals in the faith-based communities can support members of their communities with mental health, SUD, and IDD needs. So first, let's define mental illness. Mental illnesses are health conditions involving changes in emotion, thinking, or behavior, or a combination of all of those. And mental illnesses are associated with distress and or problems functioning in the social, work, and or family activities. Mental illness is common. In any given year, 1 in 5 or 19% of the US adults experience some form of mental illness. 1 in 24 or 4.1% has a serious mental illness. 1 in 12, 8.5%, has a diagnosable substance use disorder. The important thing to note is mental illness is treatable. Most individuals with mental illness continue to function in their daily lives, and that's according to the American Psychiatric Association. So we're going to have a quick discussion about the 3 divisions of mental health services. You have intellectual developmental disability, or IDD, and so these are developmental disabilities that can cause mental impairment, physical impairment, or a combination of both. Then you have mental health, and mental health includes our emotional, psychological, and social well-being. It affects how we think, how we feel, and how we act. You have substance use disorders, and substance use disorders occur when the reoccurring use of alcohol and or substances causes clinically significant impairment, including health problems, disability, and failure to meet major responsibilities at work, school, or home. So let's talk about some of the different types of mental health professionals. And you might be familiar with some of these, but you have a psychiatrist who is a medical doctor who specializes in the diagnosis, treatment, and prevention of mental illnesses, including substance use disorders. And among some of the treatments that psychiatrists might use in addition to medication is also talk therapy. Then you have psychologists who are individuals with doctoral degrees, and they have specialized training in mental health conditions. They most often help people with mental illnesses by providing testing and psychotherapy. You have clinical social workers who address the individual and family problems such as serious mental illness, substance use, domestic conflicts through counseling, therapy, and advocacy, and most of them have a master's degree in social work. Next, you have psychiatric nurses who work with individuals, families, groups, and communities, assessing and helping treat their mental health needs. You have licensed professional counselors, or LPCs, who assist people with many types of problems, including mental health issues. You also have certified pastoral counselors who are counselors, but they also have an in-depth religious or theological training and training experience in counseling. You also have licensed marriage and family therapists, or LMFTs, who provide treatment within the context of a family or relationship or any type of dyad situation. And finally, you have primary care physicians, which most of you are probably familiar with. And these are doctors or physician assistants or nurse practitioners who are usually the first person to identify or address any type of mental health concerns that an individual may have. Because that's the individual that usually you would just go to, if you're feeling sick or you're feeling down, not feeling yourself. And so they're usually that first line of defense. So next we're going to go over some common mental health disorders. The most widely used criteria for diagnosing mental health can be found in the American Psychiatric Association Diagnostic and Statistical Manual of Mental Disorders, or the DSM, which is the 5th edition. You have neurodevelopmental disorders, schizophrenia spectrum and other psychotic disorders, feeding and eating disorders, disruptive impulse control and conduct disorders, substance-related and addictive disorders, and many more. But the two we're going to focus on for the presentation are depressive disorders and anxiety disorders. And I want to make it very clear too, the purpose of today's training or the presentation is not for you, to receive this information and diagnose yourself or diagnose other people. I want to be really clear. The only individuals that can diagnose a person with a mental health issue or mental health concern are trained mental health or medical clinicians. This is just information for you to learn and to grow and expand your toolbox and your knowledge to reduce stigma related to mental health. So depressive disorders. Depressive disorders are characterized by sadness severe enough or persistent enough to interfere with function and often by decreased interest or pleasure in activities. General emotional state of mood disorders is distorted or inconsistent with your circumstances and interferes with your ability to function. Mood disorders may be characterized by periods of extreme sadness, irritability, or periods of depression alternating with being excessively happy. Three major types of depressive disorders are major depressive disorder, which is typically what you think about when you hear about someone saying that they have depression, is major depressive disorder. That's the most common one. Then you have persistent depressive disorder, also known as dysthymia. And dysthymia is not a lesser version of depression, but it's kind of like an individual that always has an overhanging cloud of sadness, or they kind of don't know exactly why they're sad or why they're depressed, but just kind of like that ongoing feeling of sadness. Then you have other specified or unspecified depressive disorder. You have some depressive disorders that are classified by etiology, in meaning that there are certain biological factors that are contributing to that depression. So you have premenstrual dysphoric disorder related to their premenstrual status. Then you have depressive disorder due to another medical condition, and that is a depressive disorder that might be related to an individual who has a medical condition, such as maybe their medical condition has bound them to a bed, and therefore they're experiencing symptoms related to depression because of their physical condition or their mental condition. And so again, the idea would be with that is if this individual was not experiencing their current medical condition, that they may not be experiencing the depression. And then you have substance medication-induced depressive disorder, which of course means depression, or depressive features related to the use of a substance. So what are some symptoms of depressive disorders? Well, it's normal to feel sad when you lose a loved one, when you're experiencing a divorce, when you're experiencing a breakup, or just having financial issues. But when sadness is coupled with other symptoms and it lasts for months and it interferes with your daily functioning, that is where it may have crossed into depression. And so symptoms include a persistent sad, anxious, or empty mood, or excessive crying, reduced appetite and weight loss, or increased appetite and weight gain, Persistent physical symptoms that do not respond to treatment, such as headaches, digestive disorders, and chronic pain, irritability, restlessness, decreased energy, fatigue, just kind of feeling slowed down, sleeping too much or too little, early morning waking up, loss of interest or pleasure in activities, difficulty concentrating, remembering, or making decisions, and thoughts of suicide or suicide attempts. We want to make sure too we have a conversation about what's the difference between sadness and depression. A lot of times you'll hear individuals say, "Oh my gosh, I'm depressed," but depressed is different than sadness. And sadness is an emotional reaction, whereas depression is an actual mental illness. Sadness is brief and is specific. Usually there's something that has triggered sadness. You're sad, like we said, about a breakup. You're sad about experiencing financial issues. So it's something that's specific, that is why you're experiencing that emotion of sadness. Whereas depression is persistent and is vague. So it's something that, can go on for months to years. And also you might not be able to pinpoint exactly why you are feeling this way. Sadness is subjective. So again, of course, it's based off of however you're feeling in that moment, what you're experiencing. Whereas depression is objective and it has to be diagnosed through a trained clinician. And it's something that if you meet certain criteria, that means that you are depressed. Sadness has short-term effects, whereas depression has long-term consequences. Sadness affects your mood, whereas depression affects your life. And when we say it affects your life, meaning, this is something, if an individual is experiencing symptoms related to depression, it might be interfering with their abilities to work. It might be interfering with their abilities to drive, their abilities to take care of their family or other responsibilities. And so it is something that it has long-term impacts and effects in your life. Next, we're going to move on to anxiety disorders. And so anxiety is distressing, unpleasant emotional state of nervousness and uneasiness. Its causes are less clear. Anxiety is less tied to the exact timing of a threat, and it can be anticipatory before a threat, persist after a threat has passed, or occur without an identifiable threat. Anxiety is often accompanied by physical changes in behaviors like those caused by fear. Anxiety disorders are the most common mental disorder in America. You have agoraphobia, anxiety disorder due to a medical condition, generalized anxiety disorder, panic disorder, and substance-induced anxiety disorder. Anxiety disorders and symptoms. So anxiety is your body's natural response to stress. Everybody experiences anxiety. It is the feeling of fear or apprehension about what may come. If feelings of anxiety or extreme last longer than 6 months and interfere with your daily functioning, it may be an anxiety disorder. So again, similar to depression, anxiety is a natural response for individuals to feel. But of course, when it moves beyond a certain time frame, that starts to impact your day-to-day, that is when it moves from just being anxiety to be possibly an anxiety disorder. So some symptoms for anxiety disorder, generally speaking, include feeling nervous, restless or tense, having a sense of impending danger, having an increased heart rate, breathing rapidly, sweating, trembling, feeling weak or tired, trouble concentrating or thinking about anything other than present worry, having trouble sleeping, experiencing gastrointestinal problems or stomach issues, having difficulty controlling worry, and then having the urge to avoid things that trigger that anxiety. So what is the difference between anxiety and then stress? So again, you think about someone saying, "Oh my gosh, I'm so anxious, I'm so stressed." You hear those terms used interchangeably a lot of times, but there are differences, and we want to make sure that we cater to those differences, especially as is considered, especially considering, individuals who are actually diagnosed with anxiety disorders, and just being respectful and highlighting things to reduce stigma. So stress is a response to an external cause, such as an argument with a partner or increase in work expectations, and it usually subsides once whatever that particular issue has been resolved. Anxiety is a person's specific reaction to stress, and its origins is internal, meaning it's something that you are experiencing and there's not like an external trigger for that. Stress, usually once you address the issue head on, can usually help with, relieving that stress and reducing that stress. Whereas anxiety is typically described as a persistent feeling of apprehension or dread in situations that are not actually threatening. And anxiety can escalate into an anxiety disorder. Again, with stress, usually it's managed through physical activity, breathing exercises, adequate sleep, and taking time to connect with others. Anxiety, stress can actually be a common trigger for anxiety. When we think about common mental health disorders, and again, thinking about triggers and causes, there are a lot of common triggers when you think about depression and anxiety and just mental health disorders in general. Some common triggers for anxiety and depression include early trauma or abuse, family history and genetic disposition, and certain medical conditions such as heart arrhythmias, thyroid issues, and sleep disorders. Also, some things to consider are ethnic and cultural differences can pose a risk factor for anxiety, depression, and other mental health issues. Exposure to racism, sexism, xenophobia, effects of systemic discrimination such as employment, your environmental factors, and access to care, and then higher rates of trauma such as assault and community violence. And we'll kind of dig into a little bit more of those when we break down some of the ethnic differences as far as like mental health considerations. Common mental health disorders and treatment for such include support. And so with support, that includes, getting support from your tribe, from your community, such as a faith-based community, if you're a member of a church, a member of a mosque. Also, receiving psychotherapy. So psychotherapy is typically, you think about like that talk therapy. That might also include group work. So just different clinical support and treatment needs. And then, of course, medication. So for some individuals, they may choose to receive medication to kind of support with their mental health needs. And so there are, of course, antidepressants. You think about medication to help with anxiety and those types of things. And those medications have to be prescribed by a medical professional. Some common mental health disorders, when we think about the Latinx and Hispanic community, just want to throw out some numbers there. That way, those who are watching this presentation have a better understanding of just how impactful mental health is on different communities. So for the Latinx and Hispanic communities, 18.3% of the U.S. population considers themselves Latinx or Hispanic. Within that 18.3%, over 16% reported having a mental illness in the past year. Research shows that within the Latinx or Hispanic community, older adults and youth are more susceptible to mental distress relating to immigration and acculturation. Per SAMHSA's National Survey on Drug Use and Health, overall mental health issues are on the rise for Latinx and Hispanic individuals. Major depressive episodes has increased amongst Latinx and Hispanic individuals. So some treatment considerations in supporting and working with individuals who are members of the Latinx or Hispanic community. Communications barriers due to a shortage of bilingual or Spanish-speaking mental health professionals. Language barriers with mental health evaluations. Medication as a means of treatment for Latinx or Hispanic children and adolescents is used at half the rate of white children and adolescents. And this information is from the Mental Health America website and information and resources that they provide. Common mental health disorders and issues related to Black and African American communities. 13.4% of the U.S. population is Black or African American. Over 16% reported having a mental illness in the past year within that 13.4%. African Americans or Blacks of all ages are less likely to die by suicide. However, Black and African American teenagers are more likely to attempt suicide than white teenagers. Major depressive episodes has also increased amongst African American individuals of all ages. Treatment considerations for the Black and African American community is stigma and perceived judgment prevents African American and Black individuals from seeking treatment for their mental health needs. Only 2% of mental health professionals are Black and or African American. And so there are concerns of cultural competence and understanding amongst the mental health professionals. Black and African American people are more often diagnosed with schizophrenia and less often diagnosed with mood disorders compared to white individuals with the same symptoms. Black and African American individuals are offered medication or therapy at lower rates than the general population. For the Asian American and Pacific Islander, or AAPI community, 6.1% of the U.S. population considers themselves Asian American or Pacific Islander. Within that 6.1%, 15% have reported having a mental illness in the past year. Suicidal thoughts, plans, and attempts, although lower than the average U.S. population, are rising amongst members of the AAPI community of all ages. Major depressive episodes have increased amongst the AAPI individuals of all ages. Treatment considerations include language barriers that pose a challenge in assessing mental health services, lack of awareness of resources and services that are available, and stigma around seeking mental health support. Regarding the Native American and Indigenous community, 1.3% of the U.S. population are Native American and Indigenous. Over 19% having a mental illness or reported having a mental illness in the past year. Native and Indigenous individuals report experiencing serious psychological distress 2.5 times greater than the general population over a month's time. Suicide rates are similar between white Americans amongst adults. However, the suicide rate for Native American and Indigenous teens between the ages of 15 to 19 is more than double of non-Hispanic whites. Some treatment considerations include cultural differences in how Native Americans and Indigenous individuals may express emotional distress, may not be consistent with standard diagnostic categories. Economic barriers and access to treatment and services, and then lack of awareness of culturally competent programs and services. With all that being said, with all the different groups, there is a common thread of treatment issues amongst all communities, regardless of race, gender, identity. And that common thread is individuals from varying walks of life seek counsel and support regarding their mental health needs from leaders and members of their faith-based communities. Now I'm going to pass it off to my teammate, Terrell, to just show how we can bridge that gap with mental health in the faith-based community.
Thank you, Monae. Hope you have enjoyed the presentation thus far. We will now get more into the application pieces of our presentation. When we consider the wellness pieces of spirituality and when we think of mental health and faith-based, looking at the 8 dimensions of wellness. Within the 8 dimensions of wellness, at Cardinal, we operate under the SAMHSA model of wellness, and we tailor our trainings and community health models with the goal of increasing awareness with the 8 dimensions of wellness. Wellness is a state of beyond absence of illness, but rather aims to optimize well-being. The World Health Organization defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So when you think spirituality, one thing we get on our mind of what is spirituality to us? Spirituality is a broad concept with room for many perspectives. In general, it includes a sense of connection to something bigger than ourselves, and it typically involves searching for meaning in life. Christina Puchalski, medical doctor, which is the director of the George Washington Institute for Spirituality and Health, she contends that spirituality is the aspect of humanity that refers to the way individuals seek and express meaning and purpose and the way they experience their connectedness to the moment, to self, to others, to nature, and to the significant or the sacred. The word spirit in English comes from the Latin word spiritus, which means breath. Although we often think of spirituality as something special or apart from our ordinary daily life, it is really as close to us as our next breath. A traumatic event can literally take our breath away and leave us feeling numb, distressed, or even disconnected. An important part of healing is to repair the sense of separateness within ourselves from others, and how we can regain our spirituality and our deep connection to all life in difficult times. So when we think spirituality, we're thinking how we can allow it to help us heal during traumatic times. So to provide you with a brief history of mental health and religious institutions, there is documentation that supports ancient connections between religion and community health. The earliest evidence of institutions supporting medical cures and treatments for varying ailments were in ancient Egyptians. Also in ancient Greece, there were temples dedicated to healer deities. Patients could visit the temples for treatments and cures, and some were put into dream or euphoric states to receive guidance from a deity. Also, the United States National Library of Medicine credits the hospital as being a product of medieval Islamic civilization. The Islamic hospital provided a range of services: home for patients recovering from illnesses or accidents, an insane asylum, a retirement home for seniors, or even a sick community for members. Now, as we look deeper into it, we want to distinguish between what is crisis and what is trauma. Crisis is a state of emotional turmoil or an acute emotional reaction to a powerful stimulus or demand. There are three characteristics of crisis. One being the usual balance between thinking and emotions is disturbed. The usual coping mechanism fails, or evidence of impairment in an individual or a group. Crisis may occur when individuals face actual or threatened death, serious injury, or some other threat to their physical integrity. Individuals may also be victimized by witnessing these events occurring to others. Contradictions to some deeply held beliefs can cause crises. One training that we offer and that we host with Cardinal Innovations is secondary trauma. Things that may not happen to you, but you may witness an event, can cause a crisis or can cause trauma to you. Then we look at what is trauma. Trauma is experiencing or witnessing an event involving actual or threatened death or serious injury to yourself or to others. So what are some types of trauma? Trauma could be the death of a loved one. It can be domestic or family violence. It can be a divorce or a separation, community violence. It can be a natural disaster, sexual, physical, emotional abuse, homelessness or housing insecurities, a major surgery or a life-threatening illness, or even war or political violence can cause trauma. So when we put these together, understand what questions survivors may ask. They may say things like, why is this happening to me? Who or what is God? Why is God punishing me? Why did I survive when others didn't? Are people good or evil? Or did I do something to make this happen to me? These are some questions that individuals may ask when they're in the midst of a mental health crisis or when they're trying to heal from a traumatic incident. When we think of stigma around the topic of mental health and faith-based communities, let's define stigma. Stigma is the disapproval of or the discrimination against a person based on perceivable social characteristics that serve to distinguish them from other members of society. Social stigmas are commonly related to culture, gender, race, intelligence, or even health. So when you look and think about it with talking about mental illness, there was a poll that was taken. How often do pastors speak to churches in sermons or a large group, and they add in their messages about mental illness? It was shown that about 3% may talk about it several times a month, whereas 66% may talk about it once a year, rarely, or even never. Or even helping with mental illness. Among pastors, the question was asked, I'm reluctant to get involved with those with acute mental illness because it takes too much time and resources. 22% agree, 74% disagreed. And lastly, mental health resources need to be communicated and made available. So when polling that, when we look at stigma, you think some people are comfortable with talking about it, some are not, but it's important and it's great to note that there are a great majority that do understand that it is important that it should be talked about. So now we get into what is a bypass. We hear this, and when you think of that, the first thing that pops in your mind, I'm sure, is a bypass is a road or a highway that is a built up area over a town that let traffic flow through without interference from local traffic. So when we think bypass, I'm sure most of our minds automatically goes to traffic, or we think about that particular bypass. But when you look at going deeper into spiritual bypass, what is spiritual bypass? Spiritual bypass is a tendency to use spiritual ideas or practices to sidestep or avoid facing unresolved emotional issues, psychological wounds, and unfinished developmental tasks. This term was developed in 1984 by John Wellwood, a Buddhist teacher and psychotherapist. Employing spiritual bypass tends to overemphasize, the positive and avoid the negative. So here's some examples, and I'm sure saying these, many of us have said these and not realizing we were spiritually bypassing. So someone may say, how are you? You're too blessed to be stressed, or are you okay? Just pray about it, or this too shall pass. And understand this is not to discourage prayer, meditation, or other means of practicing religion, holiday observances, or spiritual practices. These practices and rituals are important, and they are essential protective factors and keys of wellness. These give practice and use of this process a name. That's what spiritual bypassing does. It's giving it a name. It's not saying that telling someone that they're too blessed to be stressed is bad. It's saying when we bypass it to avoid having the conversation is when we may need to think about, are we really doing it? Are we ignoring what they need in the moment by spiritually bypassing it to a high moment? So it's just important to note that. It could be used as a protective factor. It could be used as a defense mechanism. It allows us time to think, to give process, to be able to give a better answer later on. But we have to understand, are we giving people what they need in the moment? How can faith-based communities support mental health awareness and be inclusive? One way you can do it, increasing awareness about mental illness and work towards dispelling myths and stereotypes in your community, in your faith-based community, wherever you worship, creating safe environments within those places, providing workshops, trainings, sermons, having movie nights, lectures that discuss mental health and wellness, creating community resource and guides with information about available resources to have available within your places of worship, collaborate with other faith-based communities and entities to address community wellness. And it's important to develop an on-site crisis plan to address any mental health crisis. Also, providing that individual or family with support for those who live with mental illness. Visit the hospital if able, offer prayer, send cards, send a letter, listen and offer moral support, offer meals, help with transportation to appointments, encouraging networking within the community, providing spaces within your faith-based places of worship for wellness programming, for support groups, for physical movement activities, host awareness events. You think about there are different events for different months. For instance, May is Mental Health Awareness Month. September is Recovery Awareness Month. April, Child Abuse Prevention Month. July is Minority Mental Health Awareness Month. So creating events around themes for months. Also develop relationships with mental health professionals and community entities that support mental health awareness, such as community paramedics, mental health officers, social workers, and therapists that you may be able to bring in from time to time into your places of worship to help support individuals and families with those needs. Also, and I know that my teammate Monae highlighted this earlier, the purpose of this is not to for you to assess anyone, but we do want you to be aware on what signs to look for and the way to better serve those that are around us. So when you are looking for ways to better serve and to better help, what are you looking for in that person? You're looking for levels of distress. How much distress, discomfort, or anguish that they are feeling? How well are they? Are they able to tolerate? Are they able to manage? Are they coping well? Are they able to care for themselves? Their level of function? Are they able to problem solve and make decisions for themselves? And the possibility for danger. Is there a danger to themselves or to others, including thoughts of suicide or risky behaviors? Here's the question: when to make a referral to a mental health professional? Faith leaders or members within faith-based communities may be unsure. When do you refer an individual to a mental health professional? Situations when prompt or immediate referral to a clinical care professional is indicated. When a person poses an immediate danger to themselves or others. When a person is demonstrating an emotional or behavioral problem that constitutes a threat to the safety of the person or to those around them. For instance, if they have suicidal behavior, if they're acting more aggressively around others, eating disorder that is out of control, self-mutilation, like you notice that they have been cutting themselves, or other self-destructive behaviors, or even we think suicide. Thoughts of suicide should be always taken seriously. A person may not share these thoughts with you, but the family members may be aware of concerning behaviors like isolation. A person who is seriously suicidal should be considered a psychiatric emergency. An immediate psychiatric evaluation and consultation should be sought. Do not hesitate to contact 911 for EMS for assistance. If you need law enforcement, it's important to note that you request a CIT, which is Crisis Intervention Trained officer, or a mental health officer if they are available within your county or region. Next question that someone would ask is, how do I make the referral for treatment? If possible, in your plan that you develop within your faith-based community, it's important to have a list of professionals on hand for immediate reference. In some instances, it may be helpful to provide help with finding a professional and making that appointment for them. You can visit MCO's website or call the Access Helpline for a list of providers in your area. Contact an insurance company for a list of in-network providers or agencies. You may also wish to develop a professional relationship, as stated before, with mental health professionals and providers within your area in case you need them in the event of emergency. Follow up. Remain connected with the family to see how the situation evolves. Provide the necessary spiritual encouragement necessary to stay the course, and offer community resources, which we will provide to you at the end of this presentation. Support the person's reintegration into your faith community. They're going to need you after the crisis. Find ways to support them to come back. Keep in mind, not all individuals and families will immediately accept the need for referral. And if this is the case, continue to journey with the family in providing guidance. Again, for emergencies, call 911, go to your nearest hospital, and if law enforcement is needed, please request a CIT or a crisis intervention trained officer if they are available in your area. If there is a life-threatening situation, the referral process should not proceed calling 911 or going to the nearest ER, emergency room. Also, with how to communicate clearly about the need for the referral. Make the referral a collaborative process between the person and the family and you as the faith leader. Be clear about the difference between spiritual support and professional clinical care. Example of what you can say, let us think together about the resources needed that can get you the best help that you need, that will be of most value to you. Those are the terminology you can use so they can distinguish between you providing spiritual support and them getting the necessary clinical professional support. Also, reassure the individual and family that you will journey with them and help them navigate any obstacles. Seek to understand the possible barriers and preconceived ideas that may hinder the process. There may be fear. It may be the stigma. They may not want you to do anything because they don't want you to know about their crisis. The religious misunderstandings, financial challenges, and there may be many more, but consider the barriers. Ask about medical insurance. Medicaid, state-funded, uninsured individuals are covered. There are coverage by their local MCO, and Cardinal Innovations is a managed care organization. Some individuals may have private insurance or have access to EAP or their employment assistance program within their jobs that they can call their employer and get that information, and they can get free services through their jobs. Some community agencies also provide free services such as domestic violence programs, public health departments, housing programs, and family advocate programs, and there are many more. So here's the question, who do I call? Cardinal Innovations Healthcare, please reach out to us. There is 24/7 crisis support and information available. Our access line, you can call 24/7, again, 1-800-939-5911, or on your mobile device, you can dial **ask or **275. Visit our website, www.cardinalinnovations.org, or you can email to memberquestions@cardinalinnovations.org, and we do have a specialist that monitors that email that can respond. Also, dial in from your phone, 211 will help you with local resources and help on also the website, www.211.org. Also, the National Suicide Prevention Lifeline phone number is 1-800-273-TALK or 1-800-273-8255. The website and the live chat you can find at www.suicidepreventionlifeline.org. Lastly, Crisis Solutions North Carolina at crisissolutionsnc.org. And for non-emergencies or for non-Medicaid recipients, please reach out to their primary care physician, insurance company for a list of providers, and again, their employee assistance program through their jobs for employee benefits. Now we want to talk about just some helpful resources that, along with the numbers that we just provided to give you, you can reach out to NAMI, which stands for the National Alliance on Mental Illness. That website, www.nami.org, 1-800-950-NAMI, or you can text the word NAMI to 741-741 for immediate assistance. You can look for the mental health, a guide for faith leaders, which is found at the American Psychiatric Association Foundation. Again, you can reach out to Cardinal Innovations Healthcare at www.cardinalinnovations.org, or you can reach out to your local Department of Social Services within your county. And also looking within your county for community mental health agencies within your local communities. And lastly, Depression and Bipolar Support Alliance, the DBSA, you can find at 1-800-826-3632. Website is www.dbsalliance.org.
Thank you, Terrell. So for those of you that are interested in learning a little bit more information about some other training opportunities and some other educational expansion opportunities brought to you by the Community Operations Department at Cardinal Innovations Healthcare, we offer a litany of trainings. We offer Achieving a Better Life Experience. Terrell mentioned Secondary Trauma and Self-Care. We also offer a number of multi-day trainings, such as Wellness Recovery Action Plan, WRAP, or Whole Health Action Management, or WHAM. And these trainings are offered free to the community. If you're interested in setting up any of those, like I said, expanding your knowledge base, reducing stigma, just feel free to send an email to the email that Terrell provided, or reach out to us with our contact information that you'll see at the end. For those that are interested in learning a little bit more about some of the articles and journals that we pulled some of this information from, here's a list of our references, and feel free to peruse those. For those that are participating via live action, you can complete a survey just to let us know how we did today. And also just to give us some feedback on some future presentations or trainings that you may be interested in hearing and being brought to your community.
Again, we thank you so much for joining us today for mental health and faith-based communities. If you would like to reach out to Monae or I for more information, our contact info you can find on the screen. And again, thank you so much for supporting Cardinal Innovations Healthcare.